Welcome to AETCM, the emergency medicine channel. A 54-year-old female presented to the ER with complaints of acute onset headache since one day. On our initial 10-second assessment, airway was patent, no secretions, no C-spine tenderness, appears normal. Coming to breathing, air entry bilaterally equal, respiratory rate of 18 per minute, saturation of 98% in room air. Coming to circulation, BP of 140/80 millimeters of mercury, pulse rate of 70 per minute. Coming to disability, GCS of E4, V5, M6, pupil 2 millimeter bilaterally equally reacting to light. Coming to exposure, temperature of 98.2 degree Fahrenheit, GRBS of 140 milligram per deciliter. The patient gives a pain score of 6/10 at this point of time. So we have given injection PCM 1 gram IV stat. Coming to adjuncts primary survey, we have again at this point of time reassessed the patient. The pain score was 4/10. Adjuncts, we haven't taken any adjunct at this point of time. Coming to sample history, a 54-year-old female, known case of type 2 diabetes, hypertension, gastroesophageal reflux disease, history of previous episodes of migraine, not on any medications, presented to the ER with complaints of acute onset headache of 1 day duration. It was gradual, progressive and localized to the bifrontal region, and it is associated with photophobia, nausea and history of weakness of the left upper limb and lower limb at the onset of headache. The patient also gives history of decreased sleep, history of skipped meals and a loss of appetite. No history of any fever, altered behavior, no history of any trauma, no other associated symptoms. Coming to past history, the patient had history of similar episodes in the past. The previous migrainous headache was localized to the frontal region and it was a band-like sensation. Coming to medication history, the patient is a known case of type 2 diabetes and hypertension on metformin, glimepiride, sitagliptin. For hypertension, telmisartan and amlodipine. Last meal was taken around 6 a.m. Coming to systemic examination, no pallor, no icterus, no cyanosis, no clubbing, no generalized lymphadenopathy or pedal edema. Coming to systemic examination, CNS, GCS was 15/15, moving all 4 limbs, power 5/5 on all the 4 limbs, pupil were bilaterally equally reacting to light, cranial nerves were normal, cerebellar signs were also normal. Other systems was within normal limits. Since the patient gave a history of migraines headache in the previous episodes and since the patient is having similar episodes but on varying intensity and a changing pattern with a history of weakness over the left upper limb and lower limb, we taken it as at present as a complicated migraine and we also advise for a MRI stroke protocol.
So how long was this other symptoms? Patient had some other symptoms, right? So how much time that lasted?
The symptoms.
Other than headache, what other things patient had?
The patient had photophobia, the patient had nausea and the left upper limb and lower limb weakness.
Weakness was there. So how much time did it last? So when the patient presented to ER, those symptoms were not there. When we checked the power and all, it was normal. So how much time did it last?
Approximately, ma'am, 1 hour, ma'am. On and off symptoms, fluctuating symptoms she is saying actually.
So can we call it as an aura symptom?
Yes, ma'am. Take it as aura.
So when what all symptoms are considered as aura symptoms of migraine?
Can be sensory aura, visual aura, motor auras can be there. In visual auras, there can be floaters, any zigzag lines can be there. And sensory auras and motor auras, there can be abdominal pain, vomiting sensation, weakness can be there.
Motor weakness can be there, pins and needle sensations can be there. Along with that, patient can have sometimes they will be having some aphasia or giddiness, like cerebellar symptoms can also be there. But aura usually will last only for how much time? 60 minutes. That means 1 hour only. If it is lasting more than 1 hour only, we will consider it as atypical. Okay. So, so it can be a part of aura also. Okay. Then anything else patient had other than these symptoms? Only weakness and these things, right? Okay. Then what are the other DDs when you considered when this patient came? So one can be migraine, but this time the patient is telling a different history. Okay.
Headache can be actually primary and secondary headache based on the symptoms. In this,
What is primary headache?
Primary headache can be a group of disorders where it's a benign headache, recurrent episodic headache caused by without no organic causes. Under that comes the tension headache, the migraine, and the trigeminal autonomic epiphalgias and trigeminal neuralgias.
And cluster headache.
Cluster headache.
What is the most common headache?
Tension headache.
Tension headache. Okay.
Whereas secondary headache can be due to any organic causes, like it can be due to infections, it can be due to any tumors, it can be due to trauma, any vascular pathologies, like that.
IC bleed and IC soil or anything. Along with that, other causes of headaches can be because of any problems in the eyes, like acute glaucoma or any rhinosinusitis or any ear pain radiating to the head or temporomandibular joint dysfunction. These also comes as secondary headaches. Okay. So migraine was one of your DD. Other DD?
Other was the patient was taking metformin. So the metformin causing gastritis, we were suspecting. Patient abdominal discomfort, decreased sleep, anxiety disorders also we were suspecting. Patient had decreased sleep, low mood, depressive symptoms, everything for the past few weeks further.
So did the patient had any nausea, vomiting or anything?
Nausea was there. On arrival to ER, the patient was not having nausea, but as per the history, the patient was having nausea and episodes of vomiting was also there.
So it can be dehydration related headache also. Then what else will you suspect as a DD for headache in this female? 50, more than 50 years. Cerebral venous thrombosis can be there, but usually it will be happening in young females post-pregnancy, taking oral contraceptive pills and all. It can also be considered. Then more than 50 years.
Giant cell arteritis.
Giant cell arteritis should be suspected. And how will be the headache will be like?
There can be tenderness, local tenderness, scalp tenderness can be there.
And sometimes there can be optic neuritis like features and vision loss. These symptoms can also be there. Okay. Okay.
Then we have again reassessed the patient and the pain score was again persisting to be 4/10. At this point of time, we have given risatriptan 5 mg was given sublingually.
So first, what risatriptan was given? Then what happened?
And by the meantime, we have closed or switched off all the lights. We have closed the curtains, everything, and we have also started the patient on high flow oxygen also. After 1 hour, we again reassessed the patient. By that time, the severity came down to 2/10.
Okay. Then why MRI was done?
MRI initially we planned, since the patient complains of a complicated migraine and different from the previous history she is giving, she is having a different area. Initially it was localized to the frontal region only, usual attacks. This time the patient is having bifrontal headache, persisting headache, and the pain pattern, everything, and the nature, severity, everything was changing. That's why we have.
So anything in the MRI?
MRI was normal.
Normal. Okay. So when all will you consider a headache as a red flag headache, and when all will you consider doing a neuroimaging in a headache patient? So this patient, known case of migraine, came with a varying history with weakness and all. So that's why a neuroimaging was planned. When else will you plan?
A patient is having any focal neurological deficit, we can plan neuroimaging. Patient is having altered behavior and multiple episodes of vomiting, which precedes headache, and headache which increases in bending, cuffing, and
headache increasing with bending and cuffing means what?
Raised IC.
Raised ICP. Raised ICP can worsen with bending, cuffing, straining, these things. Okay.
And if the patient describes headache as the worst headache of life, like pointing towards subarachnoid hemorrhage.
Okay. And so if the patient is presenting with a pain which is lasting, which is worsening within 5 minutes, When what all will you suspect? Subarachnoid hemorrhage. Then, and if you are finding the BP to be very high, press can be there. Hypertensive bleed can be there, or any dissection bleed. Or we don't know whether patient previously had some AV malformation and all, that also can bleed. Okay. Then cerebral venous thrombosis also can worsen within 5 minutes. Okay. Then other headaches, if the patient is having any, this female like more than 50 years with vision disturbance and all, we need to suspect
giant cell arteritis.
Giant cell arteritis. Similarly, one eye pathology which can cause headache.
Glaucoma.
Angle closure glaucoma should be suspected. Then other headaches, if it is along with altered sensorium, fever, meningitis also should be suspected. Okay. And always consider a female who is taking oral contraceptive pills or post-pregnancy females, or with headaches in patients who is having any retroviral infections like HIV and all, we need to consider those headaches as pathological. And one more type of headache is there, which will be coming as an elderly individual, usually male, with a trivial head injury, which that headache is progressing over time. So what should you suspect? Commonly we see that in ER, no? Some trivial trauma, SDH also. In such situation, we need to consider that means a progressing headache. Sometimes slowly progressing weakness also might be there. So such patients we will have to consider doing a neuroimaging. Okay. So what was the diagnosis for this patient?
This patient, acute attack of migraine that was precipitated by, we have evaluated the patient. One is due to metformin-induced gastritis, and also the patient was having refractory errors.
Okay.
These two the factors that precipitated the headache.
Okay. So how will you differentiate between a patient with migraine? So what a most common cause of primary headache is tension headache. So how will you differentiate tension headache, cluster headache, and migraine?
Tension headache can be, usually the pattern will be a band-like sensation over the forehead and which does not affect the activities of daily living.
That means it will be mild to moderate pain only will be there. Okay.
Whereas typical migraine can be a unilateral headache associated with nausea, vomiting, and photophobia, etc. And a similar episodic pattern will be there. Migraine is headache. Whereas cluster headache is severe headache that lasts for 15 to 60 minutes, multiple episodes, and that along with autonomic symptoms can be present in cluster headache.
Okay. So based on duration, how can you tell migraine? How much time will it last?
1 hour, 1 to 2.
A migraine will subside within 24 hours. Whatever time it lasts, it will subside within 24 hours, and it will be having some precipitating agents like
decreased food, skipped meals, any stressors, anxiety, even post menstrual periods, sunlight, pollution,
reduced sleep, or some food items like chocolate, mayonnaise. These things can also cause this thing, and it will be usually unilateral headache along with nausea, vomiting, then zigzag like sensation. Sometimes patient might complain of reduced vision also. Why they are complaining of reduced vision? Because it is migraine. Why all of us develop headache? It is because of cerebral vasodilatation. So because of vasodilatation, there can be some variation in ICP also. So there can be compression and relieving of the optic tract. So sometimes they will be feeling this difficulty in vision. So such things will be there in migraine. Whereas so it is unilateral with nausea, vomiting, these things, photophobia, phonophobia and all, and it will subside within 24 hours. Whereas tension headache can start from it can last from 30 minutes up to 7 days, and it is bilateral in nature, and as you told, it will not be very severe headache. It will be mild to moderate headache only, and there won't be any other associated symptoms like what nausea, vomiting won't be there, then photophobia, phonophobia, these things won't be there, and it will be like a band like, and it can be because of some stresses, like if you are entering to a new course or a new job and all, some stresses might be there for tension headache. And other headache is cluster headache. So what are the you told there can be autonomic symptoms. So cluster headache can happen as a bundle, like a cluster. So it can be present every day, or it will be present most of the days in a week, like that. And duration can last from half an hour to 150 minutes it can last. Okay. And what are the other autonomic symptoms that patient might have?
Eyelid edema, sweating can be there, then congestion can be there.
Okay, it will be usually unilateral pain along with the eyes and nose involvement. So there can be watering of the eyes, eyelid edema, ear fullness can be there, flushing can be there, nasal discharge, these can be there. Okay. These are the symptoms. Okay, so this patient you have given paracetamol, rizatriptan and
only rizatriptan and paracetamol. Then we start the patient on flunarizine.
Flunarizine. Okay. You told oxygen was given to this patient. When will you give oxygen? Which type of headache? Cluster or
cluster headache?
Cluster headache. How will you give oxygen?
100% oxygen, 10 to 12 liters.
10 to 12 liters for
15 minutes.
10 to 30 minutes. That is main treatment of choice in cluster headache. Okay. Migraine, how will you treat the headache?
Acute attack of migraine can be treated by based on the severity, mild, moderate and severe. Mild to moderate cases we can start the patient, initial cases we can give paracetamol or naproxen can be given. Moderate cases we can give the patient on triptans. Severe cases also we can initiate the patient on triptans.
In acute pain you can give paracetamol. What other agents can you give?
Naproxen 550 mg BD can be given.
Along with paracetamol you will have to give that. What other, if paracetamol is not available? You can give ibuprofen. Ibuprofen 400 mg can be given, or you can give aspirin 900 mg aspirin, or paracetamol can be given. Along with that you will have to give sumatriptan dose.
Tablet it can be 50 to 100 mg. If nasal spray is available, 10 mg in one nostril we can administer.
Okay. And subcutaneous?
Rizatriptan is available as sublingual, like that. 5 mg can be given.
And subcutaneous sumatriptan?
6 mg can be given.
6 mg can be given. This can be used for cluster headache also. This can be given in cluster headache and migraine also. And one more thing, for vomiting, what is the best drug?
Metoclopramide.
Metoclopramide also should be given in migraine attacks. Okay. Then prophylaxis?
Prophylaxis, various agents are there. We can, if the patient is an obese patient, we can start the patient on topiramate can be given. If the patient is a hypertensive patient, we can start the patient on flunarizine or verapamil. Other agents can be propanol can be given.
Okay. When will you give amitriptyline?
If the patient is having anxiety disorders, depressive symptoms, decreased sleep, in those patients we can start on amitriptyline.
Yeah. Basically, a patient who is having some stresses, and it is usually given in case of tension headache. That can be because of some stresses. So initially acute pains we can manage with either paracetamol or aspirin or something, and based to relieve the chronic symptoms we can plan on giving amitriptyline. Okay. Now what is trigeminal neuralgia?
Trigeminal neuralgia, the patient had paroxysms of stabbing sensation along unilateral, along the distribution of V2, V3 division of the trigeminal nerve due to compression or demyelination of the superior cerebellar artery.
Okay, okay. What is the drug of choice?
Drug of choice, carbamazepine.
Carbamazepine. Okay. And this patient was discharged with prophylaxis, right? Okay. Anything else?
No.
Okay. Thank you.